Assalamualaikum warahmatullahi wabarakatuh and good morning. Yang Mulia, Academician Datuk Dr. Tengku Muhammad Azman Sharifuddin, President of the Academy of Sciences Malaysia and the Science, Technology and Innovation Advisor to the Prime Minister and the Nation. Yang Berusaha Professor Teo Yik Ying, Invited Speaker for the 2023 Dr. Ranjeet Bhagwan Singh Memorial Lecture. Yang Berusaha Puan Hazami Habib, Chief Executive Officer of the Academy of Sciences Malaysia. Yang Berusaha Professor Dr. Sheila Nathan, Chair of the ASM Dr. Ranjeet Bhagwan Singh Research Grant Program, Senior Fellows and Fellows of the Academy of Sciences Malaysia, ladies and gentlemen. Welcome to the Dr. Ranjeet Bhagwan Singh Memorial Lecture and the announcement of the 2023 Dr. Ranjeet Bhagwan Singh Research Grant recipient. Ladies and gentlemen, in the honorable memory of Dr. Ranjeet Bhagwan Singh, the Medical Research Endowment Fund was established with the core objective of supporting education for the underprivileged, regardless of their race or religion. The Dr. Ranjeet Bhagwan Singh Research Grant, a yearly initiative administered by the RBS Medical Research Trust Fund, aims to grant a young Malaysian scientist the opportunity to engage in medical and biomedical research. Today, I am pleased to have the chairperson of the ASM Dr. Ranjeet Bhagwan Singh Medical Research Grant Program, Professor Dr. Sheila Nathan, to deliver her welcoming speech. She will also introduce our esteemed invited speaker for the memorial lecture. Professor Sheila Nathan, please welcome.
Thank you, Encik Nazmi. Yang Mulia Academician Datuk Dr. Tengku Muhammad Azman Sharifuddin, President of the Academy of Sciences Malaysia and the Science, Technology and Innovation Advisor to the Prime Minister and the Nation, Puan Hazami Habib, CEO of Academy of Sciences Malaysia, Professor Teo Yik Ying, our distinguished speaker for this morning, and Dr. Tripat Narayanan, who is representing the family of the late Dr. Ranjeet Bhagwan Singh. Ladies and gentlemen, good morning and welcome to today's event, which we are starting off with the Ranjeet Bhagwan Singh Memorial Lecture. So Nazmi has already given you a brief background about how this Medical Trust Fund was established. So the activities under the Medical Trust Fund include the award of a research grant every year, as well as holding a memorial lecture annually. So the first memorial lecture was actually held in 1998. There was a span of about 10 years when there were no lectures given. So today, this morning, we are at the 16th memorial lecture, right? And the goal of this series of memorial lectures was basically to highlight recent developments and trends in biomedical sciences. So for this year, the program committee decided to highlight the theme of precision health. So to tell us more about this particular subject matter is Professor Teo Yik Ying from the Sawswee Hock School of Public Health at the National University of Singapore. Professor Teo obtained a bachelor's degree in mathematics from Imperial College in London, and then went on to complete a master's degree, as well as obtain his doctorate from the University of Oxford in the fields of genetics and statistics. He stayed on at Oxford for about 4 years as an academician, a staff member, and he was also a research fellow at the Wellcome Trust program. Okay. And then he returned to Singapore, and he is currently the Dean of the Sawswee Hock School of Public Health. In addition, he is, amongst others, a member of the Council of Scientists, the International Human Frontier Science Program, and a governing board member of the Regional Centre for Tropical Medicine and Public Health Network. He's been conferred numerous awards and honours from both the UK and from Singapore. And he is listed as an author on more than 250 publications and has trained many young scientists, including one of my former graduate students. Therefore, I am delighted to invite Professor Teo to deliver the 16th Ranjeet Bhagwan Singh Memorial Lecture. Professor Teo.
Good morning, everyone. It's a real delight and honor to be invited to deliver this lecture today. And I was reading up on Dr. Ranjeet Bhagwan Singh before I came to KL, and I think I would like to pay tribute to Dr. Singh in my lecture by highlighting the importance of interdisciplines coming together, because Dr. Singh started off as a medical practitioner, but he combined technology, he combined science to really drive forward the domains that he was very passionate about. So, as Professor Sheila Nathan introduced me, I'm not a biomedical researcher. I'm actually a mathematician who became a statistician, worked in genetics, and then subsequently had a chance to specialize in public health, or rather to broaden to public health. So in trying to bring together the different disciplines, this is how I hope I can, in my own way, pay tribute to Dr. Singh and his legacy, because I think this is the way science, medical science, biomedical science, all forms of science have to proceed, because at the heart of it, we always have to ask, the science that we do they just remain as findings in a research paper, or is there a greater purpose of advancing health, well-being of people in society? So this is why I'm actually very passionate about this area called public health. And the university made me the dean for a school of public health when I had zero public health training. So all the training that I had, or the exposure that I had to public health, was from the job, from the work that I had to do, which I would share with you today. So I've titled my talk to be the promise as well as the over-promise of precision public health, because I do think that precision health, the technologies, the data science, the genetics driving a lot of this is indeed promising, but yet there's a lot of hype that have been circulated, including by myself as an academic, where in my grant application, I talk about how promising genetic sciences will be, or precision technologies will be, to drive the well-being of people. But at the heart of it, we know there are still many steps to overcome. So during this morning's lecture, I hope I can at least show you my world that brings together mathematics, statistics, genetics, as well as public health, in trying to think more about what is the role of science that we do in society. So I thought it's useful to start off with really explaining what, in my world, public health looks like. So this is a definition of public health from a mathematician's perspective, that I see public health to really start off with the very simple fundamentals of encouraging people to go for their screening, finding diseases earlier, as well as trying to prevent complications from happening to people who are already ill. So I think Dr. Ravinder Singh, who is in the audience, would appreciate the 3 bits about prevention, screening, and control of diseases. But at the same time, public health goes beyond thinking about individuals, but really around at the systems level. Whether we think about financing, we think about communications, or we think about making sure that the programs that we put in place, like for example, the Malaysian Healthy Plate, does it work? Is it effective? Are people aware of it and practicing it? I think those are some of the key areas of public health. Now, if we agree this is the definition of public health to begin with, what about precision public health? Precision public health, really, it's just trying to now make use of technology to do all the things that we wanted to do in public health all along, to get better behavior from people, from populations, trying to make sure that government can set priorities, set government policies on health in a better, more informed way, such that we don't lose or miss out on certain groups of people in the population. That, to me, is actually precision public health. It is still public health at the heart of it, but very much aided and enabled by technology, by genetics perhaps, or by data science. And you will notice that the difference between precision medicine and precision public health, what is that difference? The difference is that the precision medicine we think about the use of technology and data science to better the health or healthcare service provision of the patient in front of the person. We don't really think too much about where the financing is going to come from. We don't think too much about the acceptance of it or the ability for people to actually ask for such technology. But the public health part comes in because when we start to think about whether it is sustainable to roll such technology out to a large group of people in the population, whether we need to educate and communicate this better, what are the government systems to put in place to support this? That's where the public health comes in. Now, I'm going to highlight, in my view, what biomedical research has been looking like all along. So, and what is that link to public health? So, generally, most of the research that we do in biomedical science can fall into this part about learning about risk factors, trying to prevent or to treat people with those risk factors. Under the risk factors part, this is where you start thinking about whether it's genes, lifestyle, the environment, how do we model this better? And you start to think about, are there differences between different groups of people? Singapore, Malaysia, we share very similar population demography, Chinese, Malays, Indians, and others. Do they have similar risk architecture that I can start to predict the risk? Very important for insurance companies. And when we start to think about prevention and treatment, again, are some of the findings, the strategies for health promotion in terms of trying to drive better nutrition, better lifestyles, will those strategies work for different groups of people? Or do you need to tailor certain approaches, perhaps for the Chinese, for the Malays, for the Indians, differently? And then start to think about, if I have international findings, how relevant would it be? That's how, in my mind, almost all types of biomedical research fall under this category. And if you think that there are areas that are different, think about COVID-19, and you would realize that during COVID-19, most of the work that researchers or even policymakers, when they start to think about policies, really fall into this map. Now, when I agree on this map now, then that's where we start to realize that the world has shifted tremendously since we discovered the first antibiotics. And you could see that I've just given a very quick, simple, simplistic even, summary of some of the technological development. But what the world is facing right now when it comes to the health of people, this is really where I like to think that we are now advancing our basic sciences. Our basic sciences of physics, chemistry. If you think through the past couple of centuries, or even the past 5 centuries, a lot of the advances in physics and chemistry started off by people observing. Professors, scientists observing what happened before they found a mathematical basis to quantify things. Now we are starting to learn the same for biology, for clinical medicine, and for public health. So this view, which is just a view of all the computer servers, is going to be increasingly common even in a hospital setting, because this is going to drive a lot of the engines behind what we call electronic medical records. And now we have AI, artificial intelligence, being put in place to interpret some of this medical records to help clinicians, healthcare workers make better decisions. So this is really where precision medicine goes beyond just genetics. I know I stand almost as a representative of genetics, but I want to highlight that precision medicine, precision public health goes way beyond genetics to also include data science. And when I come back to talk about genetics, it's always about trying to think, how would this information help to guide the decision-making of physicians, of nurses, of allied health workers, of the pharmacists, or of even individuals like you and me? Now, I made a point about how precision health, it's not just genetics. It is also records like this, where your mobile phone, are you able now to nudge people's specific behavior using a mobile phone to try and drive them towards better health-seeking behavior? So I have the opportunity to have a conversation with Tengku Asman earlier on, and he was saying about the importance to focus on human behavior. Now, nudging human behavior is the hardest. All of us here, I will be presumptuous, all of us here are highly educated. We know the importance of eating healthily, not smoking, and exercising at least 150 minutes a week, moderately intense physical activity. All of us here, highly intelligent. But how many of us actually act on this knowledge? And I think that's the tough part. Because the tough part, most of us know what constitutes right behavior, but how do we get people to behave that way? So now precision technologies are starting to try and change the space on how to move people's behavior. Now, if I've given you a very simple background on how I view the world of precision health, what are some of the questions I could ask? Well, I could start off by asking whether we can predict the risk of certain outcomes. There are many outcomes that we can think about, whether it is conditions like cystic fibrosis, or harder to predict problems like risky behavior, violent tendencies, or even your response to certain pharmaceutical agents. But at the same time, precision public health also starts to ask that question: can what we know today guide governments, insurance agents, insurance companies, healthcare agencies to set priorities about the future disease burden in order to try and make populations healthier, or simply drive down the cost of healthcare to a government? And how are we able to adopt an evidence-based approach to design health policies? That phrase, evidence-based approach, happened a lot in many countries over the past 4 years as we talk about policies to control COVID-19. But how do we actually design those policies, and where is the evidence going to come from? So this is the part where I'm going to do something rather radical. I'm going to introduce some mathematics and statistics to all of you. And you would see in a while why it is quite crucial for us to base our understanding of precision health or even precision medicine on some of this very basic mathematics and statistics. So I have a very simple proposition here. Most of us would be very familiar with a pregnancy test kit. And of course, when you use a pregnancy test kit, if you get a positive, it means that the test kit is suggesting you could be positive, or you could be pregnant. If you get a negative, the test kit is saying that it's likely you're not pregnant. I could change this to a COVID-19 test kit as well. I think nowadays we are very familiar with ART kits. Now, there is a problem with all these test kits because the test kits are never 100% accurate. So there is a possibility that you will get false positives and you will get false negatives. So your ability of the test kit to give you a true positive, so meaning a lady is pregnant, truly pregnant, and the test kit managed to successfully show a positive, the capability of that is called the power or the sensitivity. It's almost like falling back to your first year mathematics class that all of you attended. The ability to correctly show that a non-pregnant woman has a negative outcome is called the specificity. Now, it turns out that these two concepts of sensitivity and specificity is tremendously important in all precision technologies because of something which we call the base rate. And the base rate fundamentally determines the economics and therefore the implementation on some of this precision technology. Now, I'll show you a simple cartoon here. Well, it's not a live cartoon, it's just, I have an HIV test kit, which is 99.9% sensitive. And just to remind you what sensitive means, it means that it's the ability to pick out someone who's truly HIV positive, at 99.5% specific. Now, if you can have a diagnostic kit with such capability, I think most of you will agree that this diagnostic kit is very, very good. 99.9% and 99.5%. Now, I give you a real-life scenario where there is a country where all immigrants have to undergo a compulsory HIV test. And let's say, hypothetically, in a year, there's about 1 million immigrants that come through, of which 1,000 of them are truly HIV positive. So it's about 0.1% of it. Now, what does this mean if I use this test kit? It means that on average, I get, out of the 1,000 HIV positive people, I correctly identify 999 of them. I missed out one. All right, that's fine. I have to live with it. But out of the 1 million people who are actually healthy, what would the test kit show? It shows an incorrect diagnosis of 5,000 people who are wrongly classified to be HIV positive. And imagine if I go for this test and I fall into that 5,000, I'll be hugely distressed to know that I'm HIV positive. So let's just put things in perspective now. Because as the government, when I run this test, I have no idea who is truly or positive and truly negative. I only know what the test kit shows me, whether it's a positive or negative. And what me as the government sees is that I get almost 6,000 positive results in a year, of which almost 5 in 6 of them, or 5,000 of them, are all false. So now please remember this lesson about sensitivity and specificity, because in about 10 minutes' time, I'll come back to that with real examples on how precision health is going to mess up some of the economics of things. So please remember this. So that's the mathematics and statistics part that I alluded to earlier on. Now, those are the questions that I started with, that I posed to all of you. Now, the way that we answer these questions, there are 3 ways that we can think about it. And I will be presumptuous here to say that most of us think in terms of the first and the second way. Because the first way is a scientific way. Because we will ask that question around when we perform some of this analysis or research, we generate new findings, and those exciting findings made us a lot more excited to design new research projects, new experiments, to propose possible treatments. But they all fall within the realm of what we call academic research. And academic research means that people like you and me, we're excited about it, but to the rest of the population, the rest of the world, they hardly learn about it or they hardly are excited by it. People get a little bit more excited when now we start to think about translation. Translation means that now you're thinking about, oh, I have found some interesting result. Maybe I should advise and change the clinical guidelines on the way that we screen for breast cancer. Now, when you start to think about changing guidelines, changing practices, this is where your work is now starting to filter into the real world. But in this real world, it is still perhaps restricted to some hospitals, restricted to out-of-pocket payment that individuals have to pay themselves. The real impact is actually large-scale implementation. And under large-scale implementation, what is the challenge there? The challenge is, how do I influence the government, the policymakers, to now think that, wow, actually I have a better way of encouraging the right behavior, the right lifestyle in my people, and I adopt this nationwide. So you could see that the exciting questions that I posed earlier on actually have 3 different types of answers. It could be an answer in solely just research, or it could have more impactful answers that fundamentally influence the lives of everyone in the community. And I think the burden is on us, you and me, to really start thinking, are we just going to continue working in the top area in just science without really asking the question, what does that mean to translation and to national adoption or implementation? So I will use the example of pharmacogenomics from a public health perspective, because I think for pharmacogenomics, it's been going around for more than 2 decades. For more than 20 years, people have been talking about the use of genetics to guide treatment. There's this idea that once you know your genetic code, you store it on your phone, you bring it to your GP or your hospital. When you have a treatment, they plug in, they download your genetic data and offer you a type of medicine or a particular dosage based on what your genes say. That's the scientific idea. And there's a lot of hype, including from Hollywood movies, about the power of genetics. Now, I'll show you the world of pharmacogenomics from my perspective, where we've done some research in the past looking at it for large-scale adoption. And that's when I realized that the picture is promising in some ways, but not so promising in other ways. So how does the real world look like? Well, the real world starts off with what all of us here perhaps will be quite familiar. It's called the discovery phase. The discovery phase is really trying to identify which position in the human genome or which part of the human genome actually contributes in a substantial way to determine our response to drugs, whether it is by the amount of drugs that we need to take or by the kind of side effects that we get when we take those drugs. So this is really where we're trying to establish the association. You could do this in a very localized way, or you could now do whole genome sequencing, which is looking at the entire human genome for the information. You find out where it determines the response or the dosage that is required. You publish a good paper like this, and then you move on. But in order to move on, what is the next step? So you have some findings. I claim that there's this particular gene that is responsible, and I now want to bring this to the next level. The next level turns out that you need to validate this. Validation, all of us know, you get a separate cohort of patients or of people in the population. You test them again. Now you use specific data, the specific gene that you look at, and you see whether that gene really controls the dosage that is required and the response. Now, at this stage, what are you actually trying to find? You're actually trying to establish the sensitivity and the specificity. Because in the clinical validation now, you have a much more independent cohort of patients that you're able to establish the sensitivity and specificity. And based on that, you start to decide, is this still a good test to use? Because imagine a test where you have to test 1,000 patients just to benefit one patient. Then you start to wonder, is that equation going to be cost-effective or beneficial? So that is where the role of the clinical validation stage comes in. Now, I've shown you clinical discovery and clinical validation, which again accounts for, I suppose, the vast majority of our biomedical research activities when we think about the science that we do as academics. Then now we start to come to the real world. I call this the discovery phases. Now, the real world, the policymakers, they will ask you this question: have you done the health technology assessment? Basically, this is the economic analysis of the test that you're trying to propose. So when I run this economic analysis, I'm actually asking a question. I have knowledge that this genetic test is going to be clinically useful in minimizing side effects, in telling people about their drug dosages, but is it cost effective? The cost effective part is what most policymakers wonder about. Because when I go to many ministries of health, in my job right now as working in public health, we work with many governments. Many governments have also consulted us because Singapore has been pushing precision health, precision medicine. They have asked us, is it truly useful? And our answer is always, it depends. Because it depends on the economics of your own country setting. And I will show you some data on this. Because there is a drug that it's called carbamazepine. It is used for treating epileptic patients. And it turns out that there is a very useful genetic test that you can use to find out who amongst those taking carbamazepine will suffer from a side effect, a severe side effect. So in Singapore, this genetic test is included in our national health insurance scheme. Meaning, if I need to take carbamazepine, I can opt for a genetic test that the government will pay for. But the situation is different if I now need a Bacavir. A Bacavir is an HIV drug. I don't need a Bacavir. But if I do need to take a Bacavir, there is similarly a genetic test that is highly predictive of whether I will suffer from a side effect if I take a Bacavir. Now, that test will not be subsidized, despite it being a very clinically effective test, because the health economics didn't pan out or it wasn't reasonable. So it turns out that for carbamazepine, why it is cost effective is because the base rate of people in Singapore with the genetic profile to cause the side effect is pretty high in Singapore. So for carbamazepine now, you actually need to screen less people to find one person that will benefit from the test. But for a Bacavir, the genetic profile that gives the side effect is quite rare in Singapore. So for the government to say that now we will test everyone who needs a Bacavir becomes a very expensive proposition. So now you start to see the real world. The real world, from a policymaker standpoint, is never just the science. It has to include the economics of it. Because if it turns out that it is very expensive to run, and most of the people who receive the genetic test actually don't benefit from the genetic test, then the question is, should this still be something that the government pay for? Or should this be something that individuals should pay out of pocket if they want the test? So those are the questions that government and policymakers have to ask. So that's the health technology assessment part. Then I'll quickly go through, because when you start to run a genetic test, you need a pipeline in your hospital from the point that you collect a sample of the blood. Where does the blood go? Who handles that blood? Who interprets the finding? What is that pipeline that is established? And more importantly, this entire pipeline has to go through accreditation. Even if you have the pipeline, do you have the clinical, do you have the expertise to interpret the findings to family, to patients, to the family of the patients, and more importantly, to the healthcare workers? So this is now an opportunity to new hospitals that are designing their new structure, because hospitals are now thinking that I should develop a hospital IT system with a capability of interpreting this information such that if I'm a doctor, next time I order carbamazepine, on the IT system, immediately there's a screen that pops up that says, this patient should not be taking carbamazepine, recommend an alternative drug. So that requires a rethinking of the IT system that suddenly you realize goes beyond you and me as academics. But yet, this is what would drive the real world adoption of the science that you and I discover. Then there's the part about educating our doctors, our present healthcare workers, and our future generation of doctors. So we did a piece of research to really try and look at the medical curriculum of, I believe, 90 over schools of medicine in advanced economies, in high-income countries. And it turns out that only 2 of them out of 90 actually include the pharmacogenetics as part of their curriculum. So we are not even educating our current and future doctors in the use of advanced technologies. And finally, is the part about regulations. Because under regulations, I talk about financing. Who's going to pay? I talk about access. Is it just going to be in hospitals, or are you going to allow some of this test to be available in clinics? And finally, who owns the data? Now, again, at this stage, I shift the lens a bit and ask you to think about COVID-19, because I know in Malaysia, you went through the same hurdles as we did in Singapore. Instead of a pharmacogenetic test now, think about your ART test kits for COVID-19. Was it state subsidized, or did you have to buy the COVID-19 test kit yourself? Was the test only available in the hospitals, or was it eventually available in the clinics, the GP clinics? And then when you have COVID-19, who owns the data? Of course, you have a government app that holds the data and allow access to that data. So some of these features need to be put in place for the adoption to be large scale. And are there international standards on communications? What do I mean by these communications? Because we talk about the communications of pharmacogenetics, and it's trying to warn against side effects that could potentially be fatal. So again, we did some research to look into this area on communications. And what we realized is that, firstly, these are the 6 most actionable pharmacogenetic drugs out there, meaning that there is a well-established link between the drug response and the genetics of a person. And out of all the pharmaceutical agents out there, these are the 6 that are most established. If you look at what happens in, again, high-income countries, there are recommendations that are very aligned, but yet there are recommendations that are not aligned. That some countries actually say that the use of a genetic test is actionable, or testing positive is actionable, but there are some countries that stay silent on it. No information means they stay silent on the need of a genetic test. And it's not just staying silent, it's even on the vigilance. If someone tests positive. So for carbamazepine, you could see that for someone who tests positive for the specific genetic profile that will cause a side effect, you would see that some country says you can continue to use carbamazepine, but some country says please use an alternative. And yet, these are the 6 most well-established with pharmacogenetic associations. I've given you a scenario when someone tests positive, but any of you who are healthcare workers will know when someone tests negative, you can't actually say that I stepped down the monitoring. I will use the example that I used earlier on Bacavir. Imagine HIV patient needs a Bacavir. When you take a Bacavir, there's a risk of getting a very severe side effect that a person can die from it. What does that mean? The hospital will now monitor this patient very closely. Now, comes along a genetic test. YY comes along and say that, oh, I have this genetic test that is very accurate. If the patient tests positive, we switch and use a different test. If the patient tests negative, you can continue to use a Bacavir. Now, remember the hospital is already monitoring this patient carefully. But if the person tests negative, means there is no chance that the person will get a side effect, a severe side effect. The hospital, from a legal standpoint, cannot stop monitoring this patient. The monitoring continues. So what happens from a hospital standpoint or from a health system standpoint? That it is not helping the hospital save money at all with the genetic test. Because when someone tests negative, I still can't step down the monitoring. I still have to continue that rigorous monitoring. So from many governments' perspective, I should just continue my rigorous monitoring, and the first sign of a side effect, I switch the drug. So that is why, even though there is a lot of excitement around these 6 pharmacogenetics, I highlight these 6 because, again, they are the most well-established with the strongest evidence. And yet, there are varying views about whether we need to truly test or not. Now, this is how the real world looks like. And you realize that we, as researchers, focus a lot in 2 parts of this real world. And we always ask, why is it that some of my findings never get its way into real-world policies? This is why. Now, I highlighted the 3 different answers. And this is where I'm going to shift a little bit, because I mentioned that precision technology goes beyond genetics. Now, I'm going to talk about an area that is bothering a lot of ministries of health worldwide. It is around patients that take up most of the healthcare expenditure in a country. We call them frequent admitters, because patients who keep going to acute tertiary hospitals, they are the ones that cost the government a lot of money to look after them and to maintain their health. And the question is, are we able to identify this group of people? So then data scientists and even right now artificial intelligence experts have been talking about the use of data analytics, going through medical records on a routine basis to try and predict the profile of people who repeatedly or recurrently return to the hospital for treatment. If the underlying assumption here is that if I can identify this group of people early on from data analytics, then there's a good chance that if I put in place a different way of managing their healthcare, which we call a different model of care, perhaps we will reduce their need to keep coming back to the hospital. So that's the basis of trying to predict this group of people. At first admission, are we able to find out, is this person likely to come back again? And to try and manage them differently, to stop them or to reduce their times of coming back to the hospital. Now, earlier on, I showed you the mathematics of sensitivity and specificity. It is exactly the same here because you have the true frequent emitters and the true non-frequent emitters, as well as what an algorithm, a data analytics or an AI algorithm will predict on whether it is truly positive or truly negative for a frequent admission. Now, there is this concept called positive predictive value. Just means out of the positives that you find, how many of them are true? So if I have a PPV of 25%, it means that out of 4 people that my algorithm classify as frequent emitters, only 1 is a true frequent emitter. Remember the earlier example of the HIV test kit, 99.9%, 99.5%? The positive predictive value was just 1 in 6, or about 17-18%. So when we start to use this as a rollout in Singapore, in one of our hospitals, what did we see? We started to see something very disappointing. Because there are about 430,000 admissions in this particular hospital. And then there is this algorithm that was actually published with a sensitivity and specificity of 80%. Now, again, in a real world with diagnostic capabilities like this, it's already a pretty good test. What happened? It actually yielded a PPV of 3 or slightly less than 4%, which means that out of 26 people that the algorithm predicts to become a frequent emitter, only 1 is a real one. So how does that work out from an economic standpoint? Because at the heart of it, you are trying to reduce cost. I will show you some interesting data that if I didn't try to predict who are the frequent emitters, this is how much the cost to the health system would be, about 694 million in a year, plus whatever that I need to spend looking after this patient. Now, if I come along with this prediction engine and I can correctly identify a true frequent emitter, I can reduce the cost by 1/4. The cost of looking after the high utilizer by 1/4. So, and it turns out that when I do this, the cost, I can save 75% in those who are truly frequent emitters, but I also have to incur an additional cost because now I put in place a stricter, a more rigorous program to manage the health of the people that my algorithm predicts to be positive. So imagine all of you here are predicted to be positive, meaning you are going to come back to the hospital. I will now have people call you regularly and say, have you taken your medication? Have you tested your blood pressure? That increases the cost of looking after this group of people compared to that group of people that my algorithm says, you will not come back so regularly. So I will just manage them normally. Now, turns out that when we do that, the majority of times, not having an AI algorithm to do this is actually going to be much cheaper. Because we found that by imposing a data analytics solution to the problem, I actually end up costing the health system more. But it turns out that if we are able to now specialize and identify specific outcomes like renal diseases, where the ability to predict who is coming back is higher, the group is a smaller group of patients, then the mathematics and economics start to shift. And by shifting, it actually now say that we are able to put in place a prediction engine that is able to help the hospital save money. So again, this is another example of the real world. Because we are now starting to talk about precision health promotion or disease prevention. We talk about the use of lifestyle, genetics, microbiome, to try and manage the health risk of a person. At the heart of it, when you're trying to manage the health risk of a person, you're always trying to bin people into specific categories. That you are going to be very healthy, carry on with what you're doing. Another group, you're not so healthy, you need to step up. The other third group, perhaps you are already in a very bad state, you need to see your doctor, you need to take certain medication. Now, when you start to use such categorical binning with data analytics, there is a price tag when you get it wrong. And the economics of it comes in to determine what is the price tag and whether it is cost effective or not. I will use a real example in Singapore, which we are currently reviewing our policies. It is around breast screening, and it uses genetic data. Because in Singapore, right now, our policy is that the government pays for for mammogram for women 50 years and above. It's free if you go for your mammogram screening 50 years and above. But the question that researchers have, it's why 50 years and above? Because 50 years is a homogeneous cutoff for every woman in Singapore. But we all know that the risk, the inherent risk of women for breast cancer actually differs. For 50 years, there are some women who will experience the same level of risk at perhaps 46 years. Some women have the same level of risk at 44 years, some even before 40, based on their genetics, based on their lifestyle, based on whether they had children or not. So once you have this approach, this is where the health economist comes in to say, how much does it take for me to now have the genetic profile of all women above a certain age in Singapore? Balance that by the cost of having to roll in a tailored mammogram screening for different age group, as well as balancing the cost of looking after early diagnosis of breast cancer patient. And it turns out that it is actually cost effective to have a nationwide genetic profiling of breast cancer risk for women. And so this is why now the scientists have shown the science. We are now moving on to the economics. The health economists have shown the cost effectiveness. Now we go back to the policymakers and say, the science is there, the economics make sense, the implementation processes are put in place. What about the policy? This is the way that we get our findings into the real world where it influences the life of people in the community. It's the same for monitors and health coaches as well. In Singapore, there is also this nationwide program called National Steps Challenge, where we give people trackers free of charge to encourage them to use the trackers on a daily basis to take 10,000 steps. If they take 10,000 steps a day regularly, they earn money from the government. They can use the money to buy groceries, to offset their shopping grocery bills. So that is a way to use money to incentivize the lifestyle of people to get them to walk more. Then the question again comes, this time from our Ministry of Finance. It cost the government a significant amount of money to roll this out on a nationwide program. I call it nationwide, but at the moment, about 1 million people have signed up for this program. The question is it cost effective? Does it help the government save money in long-term bills, healthcare bills that are averted? Because if I exercise more today, perhaps my risk of developing diabetes will be prevented or maybe delayed by 5 years. So all of that needs to come into a calculation engine where the health economist will make decisions, evaluations on whether now it becomes cost effective or cost beneficial. So it turns out that if we now put in place, include a measurement on the productivity of people who remain healthy, the National Step Challenge turns out to actually help the country save money. And that is then the evidence that is needed by policymakers to move to the next level of pushing this in an even bigger way. So I'll end off by really highlighting very simple lessons about what needs to be done. I talk about the efficacy, the effectiveness, and the cost effectiveness part, but I think the other parts about the access, the part about cybersecurity needs to be highlighted, because I think when we start to design programs in health, in public health, in clinical medicine, we start off with scientific credibility. Hopefully, we start off with scientific evidence, but very quickly we realize that financial sustainability is of topmost priority to governments, the ability to scale operationally, whether it's viable for the politicians, for the political masters to champion this, and more importantly, whether people will accept this. These are some of the 5 core elements that have to go through. So if you are a scientist who is always asking, I have great scientific evidence, why is the government not adopting some of my findings? Think through these other 4 steps and how do we address this? Now, there are some challenges to what I've highlighted for precision health. There's still the lack of interoperable data, meaning if I have data from the hospital, can this be linked up with government records on health outcomes, on access to health insurance, or even some of the financing data? Is there that problem that academics, generally, we have that trade-off? If I want to try and push my science is easy because it depends on me and my own researchers. For me to push all the way to policy implementation, I have to work in an environment where I have very little control and power over. And that is why many academics say, my career depends on whether I get my papers published and not whether I push that policy or push my finding to real-world policy. I think this is real-world, the reality for academics like you and me. And any senior management leaders from the universities that are sitting here in the audience, start to think about what I've just highlighted. Is the role of a university just to produce papers, or is it to try and solve real-world problems? If it's to solve real-world problems, perhaps thinking about the appraisal and the promotion schemes for professors need to capture that part about recognizing real-world solutions. I talk about the data security and confidentiality. It remains a big issue for all precision health approaches, whether it is genetics or data analytics, because you start to see that it is not just Singapore that have challenges. Indonesia just last month had to discuss and debate a bill that they're talking about that is going to have digital data be shared globally. There are also issues around ethics and around cost effectiveness and effectiveness. I think I've highlighted this point. So I'll end off with sharing one example on a technology that was developed called GeneXpert. People who are working in infectious diseases will be familiar with GeneXpert. It is a very rapid diagnostic toolkit for tuberculosis. And I chose this example also to pay tribute to Dr. Ranjeet, because I know that he was a medical innovator that focused a lot on diagnosis. GeneXpert is a diagnostic test kit. It allows the finding of a person who is TB positive, and even more specifically, whether the person is suffering from drug-resistant TB. From a technological standpoint, it's a fantastic development. All right, so when I find someone who tests positive with the GeneXpert test kit, I know that the person is resistant to rifampicin, which is an antibiotic used in the first-line treatment of TB. So I should move on to a second-line treatment that doesn't include rifampicin. Now, this has been deployed commonly, mostly in low and middle income countries, because there is a cost to running it per run. On a subsidized basis, it still costs about US $20 per test. So it is still a substantial cost. So there's a lot of overseas financing to support the rollout of this. But this diagnostic test kit will fall into the realm of precision public health. It does, because it is a precision technology that rapidly addresses one critical aspect of a healthcare problem. But it doesn't address the root causes of drug resistance, because some of the root causes is because antibiotics are easily available. Some it's because the antibiotics that you buy, perhaps from the supermarket in some of our Southeast Asian country neighbors, is actually suboptimal, that it doesn't contain the right amount of active ingredients. It could be the people are not that well informed on the use of antibiotics, the ability to keep to the treatment, or because it's expensive, they don't buy it so regularly, because for some of this treatment, it is daily, some it's a few times a week. There's always this cultural belief on traditional medicine. There's this, I'll skip the global financing. But what happens when you do not tackle the root causes, but now you have a technology that tells you whether someone is suffering from drug-resistant TB? Because if the technology now says that I have drug-resistant TB, I get prescribed stronger antibiotics, second-line antibiotics instead of first-line. So without addressing some of these root causes, this machine now actually drives more drug resistance, or what we call extensive drug resistant TB. Because I now get second-line antibiotics, but I haven't actually tackled any of these root causes. So if I'm going to develop resistance, I will be developing resistance to second-line agents. So now I need to have third-line agents to be ready to treat me. So this is why in the science that we do, there is a need for us to also start to think about the real-world context and also the need for different disciplines to come in. Because when I showed some of the root causes, you will realize I need social scientists, I need health economists, I need behavior scientists in the mix as well in order to truly tackle one problem, drug-resistant TB. So I'll skip this, but I'll make the slides available so you can take a look at it. So in summary, I think precision technologies, they are free gains. It clearly allows us to make better measurements of our lifestyle, of the environment, such that we can guide and nudge the behavior of individuals, not just of you and me, but including individuals like the healthcare workers, but also nudge the behavior of even the policymakers. It is much more personalized for health promotion. It's a better way of allocating resources because we start to know which population is being neglected. And so that's really trying to move away from what we call the one-size-fits-all model that we see a lot previously in medicine and in public health. Now, there are still areas that we need to work on. Of course, there are free to-dos. I think it's important for us to understand that not all precision technologies are good for adoption. We need to decide what works at a right value for money, and then what can be scaled up successfully. At the heart of it, precision technology has a real risk of splitting a country or splitting the rich versus the poor even more. Because some of these precision technologies are very expensive. Just think about cancer treatment and you'll understand what I mean immediately. And then this bit about partnership, it sounds very cliche to include multisectoral partnerships. But you will realize that when we start to think about precision technology, it is the private sector that is going to be driving a lot of the innovation. Whether it is the private sector on digital applications on your phone, on your watch, the wearables, or even the private sector driving new models of healthcare financing. There is going to be a need for governments, academics like us, to actually work with the private sector, as well as the civil societies, the NGOs, to roll out some of this successfully, if we truly believe in it. Okay, so with that, it's been a real privilege. I hope I have done justice to Dr. Ranjeet Bhagwan Singh with this lecture. It's been a real privilege, and thank you very much for your attention. Thank you.
Thank you very much, Prof. Teo, for that comprehensive picture on what precision public health is all about, and prompting academicians to sort of decompartmentalize how they think about their research and to consider the health economics as well. Thank you so much. Ladies and gentlemen, I have to profusely apologize to you, but we have no time for questions this morning. I'm sure once the event is over at about 12:15, Prof. Teo will be happy to meet up with anyone who has burning questions for him. Right, thank you very much.
Thank you, Professor Sheila Nathan, Professor Teo Yik Ying, as well as to our audience for your attention. Ladies and gentlemen, we are currently expecting the arrival of the Minister of Science, Technology and Innovation along with our guests of honor. Para hadirin dijemput berdiri untuk menyambut ketibaan Yang Berhormat Tuan Chang Lee Kang, Menteri Sains, Teknologi dan Inovasi Malaysia, diiringi oleh Div-Div Kehormat. Yang Berhormat Tuan Chang Lee Kang, Menteri Sains, Teknologi dan Inovasi Malaysia, Yang Berbahagia Datuk Teknologis Dr. Haji Aminuddin Hasim, Ketua Setiausaha MOSTI, Yang Mulia Academician Datuk Dr. Tengku Muhammad Azman Sharifuddin, Presiden Akademi Sains Malaysia, merangkap Penasihat Sains, Teknologi dan Inovasi kepada Perdana Menteri dan Negara. Yang Berbahagia Datuk Teknologis Dr. Muhammad Nur Azman Hassan, Timbalan Ketua Setiausaha Pembangunan Teknologi MOSTI, Yang Berusaha Puan Ruzia Syafiee, Timbalan Ketua Setiausaha Perancangan dan Pembudayaan Sains MOSTI, Yang Berusaha Profesor Teo Yik Ying, Pembentang Syarahan Peringatan Dr. Ranjeet Bhagwan Singh 2023, Yang Berusaha Puan Hazami Habib, Ketua Pegawai Eksekutif Akademi Sains Malaysia, Yang Berusaha Profesor Dr. Sheila Nathan, Pengerusi Program Geran Penyelidikan Dr. Ranjeet Bhagwan Singh ASM, Wakil Keluarga Mendiang Dr. Ranjeet Bhagwan Singh, Fellow Kanan dan Fellow Akademi Sains Malaysia, para hadirin yang dihormati sekalian. Assalamualaikum dan selamat datang ke syarahan peringatan Dr. Ranjeet Bhagwan Singh dan Majlis Pengumuman Penerima Geran Penyelidikan Dr. Ranjeet Bhagwan Singh 2023. Untuk memberkati majlis kita pada hari ini, saya menjemput Encik Muhammad Iqmal Hakim untuk membacakan doa. Dipersilakan.
Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Wassalatu wassalamu ala asyrafil anbiya wal mursalin wa ala alihi wa sahbihi ajma'in. Ya Allah, kami berhimpun hari ini untuk menjayakan majlis syarah peringatan Dr. Ranjeet Bhagwan Singh dan majlis pengumuman penerimaan geran penyelidikan Dr. Ranjeet Bhagwan Singh 2023. Maka kau permudahkanlah majlis ini supaya ia berjalan dengan lancar. Kami ingin menimba ilmu sebanyak mungkin supaya kami mampu memperkembangkan potensi kami sehingga menjadi hamba yang kau redha. Kurniakanlah ilmu kepada kami, sinarilah hati-hati kami dengan hidayahmu. Segala kepujian dan kesyukuran dipersembahkan kepadamu di atas limpah rahmat perlindungan kepada kami sekalian dengan aman tenteram, sihat dan selamat sejahtera. Kami memohon kepadamu supaya diperkukuhkan perpaduan, dipererat persaudaraan dan diperkuatkan keazaman, hasrat dan cita-cita agar sentiasa mendapat keredaanmu. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Wa sallallahu ala sayyidina Muhammad wa ala alihi wa sahbihi wa barik wasallam. Alhamdulillahirabbil alamin.
Terima kasih Encik Muhammad Akmal Hakim. Para hadirin yang dihormati, khususnya pada div-div kehormat, legasi mendiang Dr. Ranjeet Bhagwan Singh masih kekal sehingga hari ini. Beliau telah mewasiatkan harta beliau kepada tabung penyelidikan perubatan RBS. Tabung ini bertujuan untuk membuka peluang pendidikan kepada golongan yang memerlukan tanpa mengira bangsa atau agama. Sumbangan beliau yang amat bernilai ini merupakan salah satu usaha untuk menggiatkan saintis dalam bidang penyelidikan perubatan untuk terus maju ke hadapan. Sebentar tadi, para hadirin telah menyaksikan syarahan peringatan Dr. Ranjeet Bhagwan Singh yang telah disampaikan oleh Profesor Teo Yik Ying. Profesor Teo Yik Ying merupakan dekan di Saw Swee Hock School of Public Health di National University of Singapore. Beliau juga merupakan ahli majlis saintis dalam International Human Frontier Science Program serta ahli lembaga pentadbir di Regional Centre for Tropical Medicine and Public Health Network for Southeast Asia. Syarahan yang disampaikan oleh Profesor Teo Yik Ying telah menerokai potensi teknologi ketepatan melalui lensa kesihatan awam. Kajian dari segi sains pelaksanaan, keberkesanan serta keberkesanan kos telah beliau jalankan ke atas potensi teknologi ketepatan tersebut. Selain itu, Profesor Teo turut mengkaji perkongsian pelbagai sektor yang penting supaya kaedah kepersisan tersebut berjaya diterima pakai. Memandangkan kita mempunyai penonton dari luar negara, izinkan saya meneruskan acara ini dalam bahasa Inggeris. Ladies and gentlemen, the beautiful legacy of the late Dr. Ranjeet Bhagwan Singh continues to shine brightly in our hearts to this day. Dr. Ranjeet Bhagwan Singh's vision of providing education and support to those in need fills us with warmth and hope. His passion and dedication continue to fuel our collective journey towards a healthier and brighter future. Today, we are honored to welcome the representative of Dr. Ranjeet Bhagwan Singh's family, Dr. Tripat Narayanan, whose presence is a reminder of the love and compassion that this remarkable individual shared with the world. Welcome to the stage, Dr. Tripat Narayanan.
Good morning. I am Tripat Narayanan, paternal niece to the late distinguished Dr. Ranjeet Bhagwan Singh. We grew up within a close-knit joint family ethos with uncles and aunts stretching from Batu Gajah, Perak through Kuala Lumpur to Singapore and Sabah. Dr. Bhagwan, though fourth in a family of 10 siblings, was always the pater uncle in the wider family. His older brothers held him in honor, respect, and deference for his brilliant educational achievement and professional medical status. His consent, given with a mere nod of the head, was the acid test of approval for school reports, educational pursuits, job applications, and even choice of life partners for all of us, his nieces and nephews. What we then construed as fear was in fact awe for this gentleman of much educational and professional achievement who appeared so far ahead of us that he seemed inaccessible. His demeanor in the family was strict and stern. Those were days of stern parenting and tough love. We never questioned him on any of his edicts and expectations of propriety in family situations. Uncle Doc, as we casually referred to him among ourselves, though never extravagant, was generous with family celebrations over food and drink and Chinese restaurant outings. He had a policy of no favor, but when he spotted endeavor, industry, and interest, particularly in educational development, he would encourage with words and sometimes with small amounts of cash as well. On a cheeky note, we sometimes referred to him as the big one, playing on his name. He believed in giving recognition and helping with a leg up towards self-help and industry. His is a legacy of recognition of achievement and modest amounts of cash awards aimed to make recipients do the rest themselves with honest and hard work. The genesis of this outlook, in all likelihood, is that initial act of kindness from an unknown donor who paid his final university exam fee when he had no money as an impoverished medical student way back in 1948 in Amritsar, India. This single act became inspiration for Dr. Bhagwan to pay forward forever. And so, at his passing, he had created a small empire of study loans, gold medals, and cash awards at universities in Malaysia and his alma mater institutions in India and the United Kingdom. Today, there is a whole brood of young medicals in the Ranjeet Bhagwan family who, we hope, will take inspiration from this legacy to cherish, honor, and maybe even extend it to become more in the spirit of our beloved and distinguished Dr. Ranjeet Bhagwan Singh. The family acknowledges with sincere and humble thanks this initiative, initially by the Ministry of Science, Technology and Environment, and now by the Academy of Sciences Malaysia, in administering the Dr. Ranjeet Bhagwan Singh Medical Research Endowment Fund, running an ongoing annual memorial program with enlightening and engaging lecture series by prominent and distinguished international and national practitioners and academics, along with the selection of an award of a recipient every year. Thank you.
Thank you, Dr. Tripat Narayanan, for sharing such a beautiful memory of Dr. Ranjeet Bhagwan Singh. Ladies and gentlemen, now let us welcome Yang Mulia Academician Dr. Tengku Muhammad Azman Sharifuddin to the stage to deliver his speech.
Bismillahirrahmanirrahim. Assalamualaikum. Selamat pagi dan salam sejahtera. Yang berhormat Tuan Chang Likang, Menteri Sains, Teknologi dan Inovasi. Yang berbahagia Datuk Dr. Haji Amiduddin Hasim, Ketua Siusaha Musti. Yang berbahagia Datuk Dr. Muhammad Nur Azman, Timbalan Ketua Siusaha. Yang berusaha Puan Ruziah Syafi'i, Timbalan Ketua CEO juga. Yang berusaha Profesor Teo Yik Ying, Pembentang Syarahan Pengeringkatan Dr. Ranjeet Bhagwan Singh 2023, Puan Hazmi Habib, CEO Akademi Sains Malaysia. Yang berusaha Profesor Sheila Nathan, Pengerusi Program Geran Penyelidikan Dr. Ranjeet Bhagwan Singh, Wakil Keluarga Mendiang Dr. Ranjeet Bhagwan Singh, fellow kanan dan fellow akademi Sains Malaysia, rakan-rakan media, hadirin dan hadirat yang saya muliakan. Saya ingin menzahirkan rasa kesyukuran kerana kita dapat bersama-sama menghadiri majlis hari ini. Ucapan penghargaan tertinggi saya kepada Kementerian Sains, Teknologi dan Inovasi serta semua yang terlibat dalam penganjuran program ini. Ladies and gentlemen, I welcome all prominent scientists, researchers, and respected guests to the RBS Memorial Lecture and announcement of RBS Research Grant 2023. On behalf of the Academy of Sciences Malaysia, I would like to convey my highest appreciation to YB Tuan Chang Likang for his presence to grace the ceremony today. A warm thank you to Professor Teo Yik Ying, Dean of the Saw Swee Hock School of Public Health at the National University of Singapore, who just shared his deep knowledge and experience in the Ranjeet Bhagwan Singh Memorial Lecture earlier today. I am sure your lecture on the promise and overpromise of precision public health will create more excitement and shed new light on how to properly manage the potential of precision healthcare. Sorry, I had to miss the last 10 minutes, but for the first 30 minutes, I took on my map, so I could remember many of the things he said. In commemorating the memory of Dr. Ranjeet Bhagwan Singh, I would like to welcome Dr. Tripat Nairanan and other family representatives who are joining us today. Ladies and gentlemen, the late Dr. Ranjeet Bhagwan Singh bequeathed his entire estate to the RBS Medical Research Endowment Fund, enabling the fund to be established in 1982 with an initial donation of Ringgit Malaysia 50,000 for research and development in the medical and biomedicine fields. ASM is honored to be the implementing institution to organize programs under the RBS Medical Research Trust Fund since 1997. To date, a total of 27 research grants, 11 technical workshops, and 2 fellowships have been organized that amount to a total funding of Ringgit Malaysia 812,265 ringgit. 16 RBS Memorial Lectures have been organized from 1997 to 2023, covering various topics in medicine and healthcare. This year, we have received 110 applications for funding, which is a significant increase from 78 last year. This attests to the intensifying demand from early career researchers for funding to support in carrying out their impactful research projects. Ladies and gentlemen, philanthropy is an act of goodwill to fellow members of the human community, especially active effort to promote human welfare. The concept of philanthropy goes beyond simple acts of charity or giving. Philanthropy can be a prime mover in addressing major human challenges in a mission-oriented way, driven by compassion and a genuine concern for the well-being of others, and ultimately providing positive and lasting impact on society. Indeed, human welfare could be promoted in various ways and should not be limited to financial instruments. Knowledge, expertise, skills, and experience are human attributes that may also be put to bear in addressing the applications of science and technology. Philanthropy in this wider sense may include all of us then, especially those who have less financial wealth to share, but much knowledge and wisdom to take development forward. Knowledge is already the primary source of innovation in modern economies and societies. It creates new wealth, part of which will be further invested in value-creating research in the self-perpetuating cycle of economic transformation based on innovation. This is the key process that drives scientific and technological progress, rendering enormous spillover effects to the broader economy and society. Ladies and gentlemen, some 4 decades ago, when this grant scheme was created, we may not have appreciated that it is part of our national science, technology, innovation, and economy ecosystem that is under development. If this ecosystem is to work well, it must be driven by a common purpose which governs its operation. In particular, the public and private sectors must come together to collaborate in pursuing outcomes that may result from effective application of new knowledge. This is called the mission-oriented approach. Complex societal challenges, such as the pandemic and a rapidly changing population, is best tackled by mission-driven research. Scientists and researchers should collaborate in finding breakthrough innovations and to accelerate the search for solutions to these societal challenges. Mission-oriented research and innovation should be viewed as a problem-solving approach to fuel innovation-led growth. The successful execution of the research project depends not only on the effort of the researcher, but also on available infrastructure to conduct the research. To all the researchers and scientists who are present today, I hope you will be proactively driven to conduct mission-oriented research, never give up in pursuing your dream, and be in charge of the change that you want to make in the STI landscape. Not to forget, to the RBS Research Grant alumni who are present today, I would like to encourage you to achieve even greater accomplishments that could further benefit the community, of course, make our nation proud. In this respect, ASM is privileged to spearhead the establishment of the Malaysia Science Endowment, MSE. It is hoped that it will attract R&D funding and donations from diverse stakeholders. By acting as a national focal point to attract and consolidate donations and contributions, the MSE may help to expand R&D activities to meet national development challenges, in particular, those that involve collaboration between the research community and industry. Ladies and gentlemen, the RBS Research Grant is a good starting point to encourage the widest possible spectrum of giving and philanthropy, especially in the landscape of research and development in science, technology, and innovation. The grant provided is essential to get the ball rolling, as it can function as a seed fund for scientists and researchers to create a multitude of mission-oriented research. Younger researchers need support of all kinds if they are to become better. Early career scientists face a special challenge in securing grants, as they may have to compete with their more senior counterparts who have the advantage of expertise and reputation. In relation to past recipients of RBS, I would like to take this opportunity to highlight a few achievements. First, Dr. Annie Chai Wai Yeng, RBS Grant Recipient 2021, a senior scientist at Cancer Research Malaysia, has made our country proud by winning the next ASEAN Innovator category in the recently concluded 4th ASEAN Republic of Korea Award Workforce Excellence in Science, Technology and Innovation in Seoul. Second, Dr. So Shea Ni, RBS Grant Recipient 2021, who has managed to secure MOSTI's Technology Development Fund 1 grant to continue the project entitled Early Detection of Intrauterine Growth Restriction Fetus Using Artificial Intelligence. This project aims to create an AI model to better predict a baby's health, to reduce fetus death, and to help babies survive. Their successes serve as a catalyst to stimulate greater interest among national research institutions and researchers to strive towards finding innovative solutions for challenging problems by leveraging on STI. Finally, I would like to convey my heartiest congratulations to the 2023 RBS Research Grants recipients to be announced later. I am convinced the recipients will be able to pursue impactful mission-oriented research that will bring greater benefit to the nation. Thank you.
Thank you, Yang Mulia Academician, Datuk Dr. Tengku Muhammad Azman Sharifaddin, for the insightful speech just now. Members of the audience, it is my great pleasure to invite the Minister of Science, Technology and Innovation, Yang Berhormat Tuan Chang Lee Kang, to deliver his speech and announce the recipient of the 2023 Dr. Ranjeet Bhagwan Singh Research Grant.
Yang berbahagia Datuk Teknologis Dr. Haji Aminuddin Hasim, Ketua Setiausaha MOSTI. Yang berbahagia Academician Datuk Dr. Tengku Muhammad Azman Sharifaddin, Presiden Akademi Sains Malaysia, merangkap penasihat sains, teknologi dan inovasi kepada Perdana Menteri dan Negara. Yang berbahagia Datuk Teknologis Dr. Muhammad Noor Azman Hassan, Timbalan Ketua Setiausaha MOSTI. Yang berusaha Puan Ruzia Syafiee, Timbalan Ketua Setiausaha MOSTI. Yang berusaha Profesor Teo Yik Ying, Pembentang Syarahan Peringatan Dr. Ranjeet Bhagwan Singh 2023. Yang berusaha Puan Hazami Habib, Ketua Pegawai Eksekutif Akademi Sains Malaysia. Yang berusaha Profesor Dr. Sheila Naden, Pengerusi Program Grant Penyelidikan Dr. Ranjeet Bhagwan Singh ASM. Wakil Keluarga Mendiang Dr. Ranjeet Bhagwan Singh, Fellow Kanan dan Fellow Akademi Sains Malaysia, rakan-rakan media, hadirin dan hadirat yang saya hormati sekalian. Salam sejahtera, salam Malaysia Madani. Terlebih dahulu, kita bersyukur kita kerana dapat bersama-sama pada pagi ini, setinggi-tinggi penghargaan kepada pasukan MOSTI dan Akademi Sains Malaysia yang menganjurkan program pada hari ini. Untuk makluman, ini adalah satu program tahunan yang amat bermakna dan dinanti-nantikan bagi mendorong penyelidik muda dalam bidang perubatan dan kesihatan dengan dana awal yang pastinya dapat membantu mereka dalam menjalankan penyelidikan yang berimpak tinggi kepada negara dan masyarakat. Dengan kehadiran tetamu luar negara, izinkan saya untuk berucap dalam bahasa Inggeris. Distinguished guests, ladies and gentlemen, with the aspiration to become high-tech nation by 2030, MOSTI prioritizes value creation and impactful research towards a harmonious, prosperous and sustainable future. This certainly includes dedicating efforts to the field of medicine and healthcare, which plays a significant role in improving the well-being of our society. Research output hold immense potential, especially with appropriate facilitation and requisite funding to deliver innovative and integrated solutions that effectively tackle key challenges faced by the nation and the society, such as health security, climate change adaptation, disaster risk reduction, and food security. In this context, let us take a moment to recognize the late Dr. Ranjeet Bhagwan Singh, an extraordinary, visionary, and philanthropist in the medical and health sciences field. It is indeed commendable that Dr. Ranjeet bequeathed his entire estate, estimated at 1 million ringgit, to be utilized to advance medical and health sciences research, especially through support for early career researchers. This extraordinary philanthropy is a permanent tribute to his visionary nature and deep understanding of the significance of supporting young researchers in pursuing knowledge and innovation. The Dr. Ranjeet Bhagwan Singh Medical Trust Fund has provided a continuous source of financing that enables deserving young researchers to pursue their passion, embark on groundbreaking research projects, and make transformative discoveries towards accelerating progress in medical and healthcare. Over 26 years, this trust has funded 27 research projects and 11 technical workshops since its inception in 1997. Philanthropic contributions are one of the categories of alternative funding for research, development, and innovation being pursued under the Malaysia Science Endowment, passed by Parliament on 4th August 2022, with ASM as the implementing entity under the purview of MOSTI. Today, as we gather here, MOSTI and ASM reaffirm our commitment to upholding the principles and vision of the late Dr. Ranjeet Bhagwan Singh. We assure everyone here that we will continue to uphold the highest standards of transparency, accountability, and fairness in fund administration. Ladies and gentlemen, one of the aspirations that I had put forward at MOSTI's gathering in June 2023 is to ensure research and development R&D as a driving force for transformative change and progress for our society. It is through R&D that we unlock new insights and push the boundaries of human knowledge. Global trends in this rapidly advancing era point towards more personalized medicine and healthcare. Malaysia too has to make strides in that direction by embracing precision medicine and digital health and positioning Malaysia as a hub for clinical trials among developing countries. These are the niche areas identified under the medical and healthcare socio-economic driver of the 1010 MySTIE framework launched in 2020 alongside the National Policy on Science, Technology and Innovation 2021 to 2030. It will revolutionize the development of new drugs, increasing the efficiency of R&D while saving cost, and will enable the medical data from ambulance to be transferred at super speed to multiple devices in hospital during emergencies. To fully harness the potential of personalized medicine, we must invest in R&D initiatives that explore new frontiers, foster collaborations, and leverage emerging technologies. MOSTI has developed 13 comprehensive technology roadmaps, plans, and policies, outlining its strategic vision for advancing various sectors. Among these 13 initiatives, an impressive 7, such as the National Vaccine Development Roadmap and Nanotechnology Policy and Strategic Plan 2021 to 2025, have prioritized integrating and implementing cutting-edge medical and healthcare technologies as their central focus areas. Ladies and gentlemen, MOSTI emphasizes the need for careful planning and successful implementation of the country's R&D direction and financing. including alternative funding to reduce dependence on government funding. As mentioned, the Malaysia Science Endowment MSE is slated to play this crucial role. MSE is more than an alternative R&D funding for the nation. The working model is to utilize its interest, which will be generated from the investment. The fund would be optimized further through a matching fund mechanism, bringing quadruple helix stakeholders together to focus on solution-driven R&D and prioritizing based on the nation's need. Implementing this initiative would complement the current R&D funding landscape, propelling the nation's gross expenditure on R&D, GERD, to gross domestic product, GDP, of 3.5% by 2030. Aligned in the Madani Economic Framework and also envisioned under the National Science, Technology and Innovation Policy 2021 to 2030. MOSTI with ASM is actively developing a fundraising mechanism to establish the MSE. A key proposal involved the setting up of a 2 billion ringgit endowment fund. The proposed model is a sharing of contributions by the government, corporations, and high net worth individuals. As we embark on this transformative journey, MOSTI believes in the power of collaboration for significant impact when corporations and high net worth individuals join hands to contribute to advancing R&D and innovation. By contributing to this noble cause, they will be recognized for their commitment to corporate social responsibility, CSR, and have the opportunity to shape the trajectory of mission-oriented science, technology, innovation, and economy. In collaboration with experts and stakeholders, the government will ensure transparent governance, effective utilization of resources, and prudent investment strategies. The government will develop a robust framework that aligns with international best practices, maximizing the impact of philanthropic contributions towards a robust STIE ecosystem. Ladies and gentlemen, I wish to take this opportunity to record my appreciation to Professor Teo Yek Ying, Dean of the So Swee Hock School of Public Health at the National University of Singapore, for taking your valuable time to share your expertise with all of us through the RBS Memorial Lecture. I'm pleased to announce the recipient of the Dr. Ranjeet Bhagwan Singh Research Grant. And this year's winner has demonstrated a commitment to pushing the boundaries of knowledge through groundbreaking work. Please join me in congratulating the winner, Dr. Fazrin Azmi from University Kebangsaan Malaysia. I look forward to the impactful research that will be undertaken by Dr. Fazrin, creating fresh insights and valuable applications for society's benefit. The aspiration held for this grant is that it will contribute to trailblazing research and transformative discoveries that go beyond conventional limits. Thank you.
Thank you, Yang Berhormat Tuan Chang Lee Kang. Ladies and gentlemen, for your information, Dr. Fazrin Azmi is the 27th recipient of the Dr. Ranjeet Bhagwan Singh Research Grant. Dr. Fazrin will receive 50,000 ringgit to assist him in his pursuit for excellence in medical research. However, Dr. Fazrin is unable to attend today's event. Nevertheless, he has prepared a video to elaborate on his current research pursuit. Please watch.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera dan salam Malaysia Madani. Yang berhormat Tuan Chang Lee Kang, Menteri Sains, Teknologi dan Inovasi, MOSTI. Yang berbahagia Datuk Teknologis Dr. Haji Aminuddin Hasim, Ketua Setiausaha MOSTI, yang berbahagia Academician Datuk Dr. Tengku Muhammad Azman Sharifuddin, Presiden Akademi Sains Malaysia, merangkap penasihat sains, teknologi dan inovasi kepada Perdana Menteri dan Negara, yang dihormati pegawai-pegawai kanan MOSTI, wakil-wakil kementerian, pengurusan tertinggi Akademi Sains Malaysia, dan yang dihormati ahli keluarga mendiang Dr. Ranjeet Bhagwan Singh, fellow kanan dan fellow Akademi Sains Malaysia, rakan-rakan media. Hadirin dan hadirat yang dihormati sekalian, izinkan saya meneruskan pembentangan penyelidikan saya dalam bahasa Inggeris. Assalamualaikum, hi, and a very good afternoon to everyone. My name is Fazrin Azmi, and I'm from the Faculty of Pharmacy of University Kebangsaan Malaysia, UKM. And of course, first of all, I would like to thank the Evaluation Committee and in particular MOSTI for giving me the opportunity to be the recipient of this prestigious Dr. Ranjeet Bhagwan Singh Grant Award. And definitely, this accomplishment is a significant milestone in my academic career. And on top of that, I would sincerely apologize for not being able to attend this awards ceremony, as I have prior commitments that has been planned long time before I knew that I was selected as the recipients for this grant. So today, I would like to share the research works that I have proposed, which is to explore the use of microalgae oil droplets as the subunit vaccines production platform, which will be specially formulated into international-based nano-vaccine formulations against COVID-19. When we talk about COVID-19, I would like to share a recent statement made by Prof. Kirill. He is an immunologist from Washington University, which stated that this pandemic has been dragging on because new variants continue to emerge that are capable of causing a lot of infections and transmissions among people, even though they were already vaccinated, which reflecting the current scenario that we are facing with COVID-19. Yes, the current vaccines are capable and workable to prevent the severity of the COVID-19 disease, but not being able to fully preventing the infections. So that's why, as of today, we can still see that there are a lot of ongoing cases of COVID-19 infections. So just imagine if we were put in a danger situations, what we think of is to survive. So same goes here, same goes to the virus. What I mean is that they will undergo mutations in order for them to evade the immune response, such as the antibody. And of course, this mutation can lead to the development of new variants, as in the case for COVID-19. As for example here, as we can see, there is a variant of concerns like Omicron, which has higher transmission ability. And what worrying is that it has led to the weakening on the first generation COVID-19 vaccines. So in fact, the more people the virus infects, the more chances it has to spin off into new variants, which eventually can sustain these pandemics, which is not what we wanted. So, and on top of that, there are always some people who can't get vaccinated or who are still at the risk of severe illness despite vaccination. And the best way to protect them is to stop the virus from circulating. Therefore, one of the approaches to overcome those challenges that I have mentioned earlier is by developing a nasal vaccines which have this capability to prevent the spread of the virus instead of just preventing the severity of the infection. And this is because by delivering the vaccine into the nasal area would induce a specific mucosal immune response, such as the IgA, which can confer protective immunity at the site of infections, or we can say that it's at the entry site of a virus, which is via the nose. So it's really important to develop this type of vaccines at this stage of the pandemic, which is to prevent the infection at the very beginning stage, which eventually can help to limit the emergence of new variants. And of course, other than that, as an addition to the advantage that I've mentioned earlier, the intranasal vaccines offer the ease of administrations, as it can just be sprayed into the nose instead of the need of professional healthcare workers, like when you have the vaccines to be delivered by using the injection, right? By having it jet on the vaccines. And on top of that, what we envision is that the next generations of COVID-19 vaccine should also be able to be developed in a quickly and rapidly, and also to be thermostable, which they should be stable, or it's best to be stable at an ambient temperature. And the vaccine also need to be safe while being effective and more efficacious, and to be capable of self-administrations, which what we can see with these intranasal vaccines. And so in here, we are currently putting an effort to develop on what we call it as a plug and play vaccine platform technologies, in which we can always substitute the vaccine antigen from different pathogens which aiming to target for a different diseases, right? So now let's talk why we are interested in microalgae. So basically, in general, microalgae is attractive as they are easy to grow for mass productions, and they are regarded as safe, and they also have high nutritional value. And in fact, in terms of vaccine development, microalgae has been widely used to express the recombinant proteins, and in some of the research, they are using the microalgae as the whole organisms as the vaccine candidates for oral administrations. So in here, we know that if you read of microalgae is also famous for the explorations as the source for the production of biofuel, which is as a renewable alternative to the petroleum fuel. And thanks to its highly content of oil compartments, which can be called or referred as oil droplets or oil bodies. So what we are interested in here is to explore the use of these oil droplets as the production platform of the recombinant protein as the vaccine antigens. So in this particular research project, we are interested to use the Nanochloropsis species. As you can see here, it has high lipid content, and on top of other features such as it has a high transformation rate. So literally, the oil droplets are composed of neutral lipid core, mainly made of these triacylglycerols, surrounded by a phospholipid monolayer, and also a various surface associated proteins. And among the proteins, The most abundant one is called the lipid droplet surface protein, abbreviated here as RBSP. So our strategy is that the immunogenic protein that we aim to produce or express in these oil droplets can be genetically fused with the LDSP and displayed within the surface of the oil droplets, as you can see from the diagram here. And as I've mentioned earlier, in regards to the plug and play vaccine platform, we can always have a different protein to be expressed here, which can be used to target different pathogens. However, in order to formulate an effective intranasal vaccines, it is not an easy and straightforward approach. If the vaccines works well when administered via injections, it does not mean that they can work similarly when administered intranasally. So as we can see here in the slides, the AstraZeneca COVID-19 vaccine failed to generate the necessary immune response when delivered intranasally. This is because there are many barriers in the nasal mucosal area which can lead to inefficient antigen uptakes, rapid mucociliary clearance, and inability to undergo permeations across the epithelial barriers. So, in order to overcome the mucosal area and all this barrier, and also to induce a mucosal immune response, such as to induce the activation of these M cells, innovative delivery systems is needed for an effective intranasal vaccine formulations. So let me share our previous work here. In our lab, we have developed a new epiphilic chitosan derivative, so termed here as ACN, where we conjugated a lipidic and cationic moiety along the chitosan backbone to enhance its immunostimulatory effects. And this new version of chitosan can self-assemble into nanoparticles and loaded with the desired vaccine antigens. So in particular, in our study here, we have shown that the use of these chitosan nanoparticles as the vaccine carrier, they managed to induce a balanced Th1 and Th2 immune response, which are significant in inducing protective immunity, especially against the virus. Where on top of the humoral, we also need to have the T-cell immune response. And importantly, the use of this nanoparticles platform induce the necessary antibody response with the neutralizing effects against tested pathogens. And if you're interested with this work, you can have it viewed in where we have published our work here in the Asian Journal of Pharmaceutical Science, as being shown at the bottom there. So basically, in this particular proposed work, we are interested to utilize this nanoparticle platform in our intranasal vaccine formulations, as we know that the native chitosan is regarded as a potent mucosal adjuvant. So here is what we have hypothesized. Our aim protein that we wish to be expressed in this particular lipid oil droplets is a multi-epitope protein immunogens, which is generally composed of the receptor binding protein, RBD, from a various or the targeted strains of the SARS-CoV-2, which act as a source for the neutralizing antibodies productions, and alongside with this RBD, it will be conjugated to a universal T helper epitopes and a highly conserved cytotoxic T cell epitopes, where our aim with this immunogen protein is to serve as a universal COVID-19 vaccine. So next, these immunogenic oil droplets will be further stabilized with our amphiphilic chitosan into the nanovaccine formulations to induce both of the mucosal and systemic immune response against COVID-19 infections, including what we aim is for this vaccine to be effective also against the targeted variant of concern strains. So finally, after we have formulates and to have the final formulation, we will characterize our vaccines formulations in terms of its particle size, stability, and its dosage, especially to confirm the presence of the desired recombinant proteins in or within the oil droplets. So here is our immunization studies planning based on prime and boost vaccination regime, where we will test our vaccine formulations in various forms and also a various route of administration, as you can see here. So for example, we will have our vaccine to be delivered by injection for the first 2 immunizations and boosted with intranasal administrations to evaluate whether we can enhance the immunogenicity effects by using this approach. As we know, most of the human populations already have received at least 2 times of COVID-19 vaccination. So basically, we will collect all the necessary samples, such as saliva and the bile fluid, to measure the IgA antibody productions and the sera for the IgG, which indicative for the systemic immune response. As you can see here, as shown in a few picture here, we already have established the bile fluid collection procedure, which is quite required some technicalities, and we are grateful by the help from Dr. Hadi, a friend of mine from for this particular techniques in terms of the bile fluid collections. And on top of that, the safety effects of the vaccines will also be evaluated by monitoring the mice throughout the vaccination process and also to examine the histopathology of the selected organs like the kidney and liver. And as you can see here, as for the positive control, we will use a CTB, which is a cholera toxin B, as the mucosal adjuvant, which is the gold standard of adjuvants for mucosal immune response induction. So lastly, with this study, we aim to provide a proof of concept on the utility of the oil droplets in assembling the immunogenic proteins as the vaccine antigens. And of course, studies emanating from the data, we hope to have some lead intranasal COVID-19 vaccines candidates that we can push forward for further immunogenicity and safety studies for the clinical translations. And we also hope that this innovative platform can serve as a universal vaccine platform productions and should or be capable to be applied to other targeted or new emerging disease. And finally, with this new technology of microalgae, we hope to boost the algae farming in Malaysia. As we know, if I'm not mistaken, there are already some established microalgae cultivation plant in Malaysia, which definitely will boost our biomanufacturing, or so-called as molecular farming. And lastly, I would like to take this opportunity to acknowledge those who have contributed significantly to my academic journey, especially our research groups, which is the Center for Drug Delivery Technology and Vaccine, or abbreviated as CENTRIC. And importantly, I would like to acknowledge all of my super hardworking postgraduate students, and a special thanks to Prof. Haliza for representing me to receive the award on my behalf today. And in a nutshell, I believe our journey towards a safer and healthier world begins with the commitment to innovative research in a collective and collaboration manner, in which alone we are just like a drop, but together we are like an ocean. With this spirit in mind, I'm always happy to explore any prospective collaborations, and I can be contacted via the emails that I have provided in the bottom of the slides. With that, thank you very much. Bismillahirrahmanirrahim.
Thank you for your attention. With that, I would like to invite Yang Berhormat Tuan Chang Lee Kang, Yang Berbahagia Datuk Teknologis Dr. Haji Aminuddin Hasim, and Yang Mulia Academician Datuk Dr. Tengku Muhammad Azman Sharifuddin on the stage for the grant presentation. Now, please welcome Associate Professor Dr. Haliza Katas, who is in attendance today to receive the Dr. Ranjeet Bhagwan Singh Research Grant on Dr. Fazrin Azmi's behalf. For your information, Associate Professor Dr. Haliza Katas is the Deputy Dean of Research and Innovation at the Faculty of Pharmacy, UKM. Now, I would like to invite Professor Dr. Sheila Nathan and Dr. Tripat Narayanan to join our guests of honor on stage for a group photo. Along with Professor Dr. Teo as well. Thank you Yang Berhormat Tuan Chang Lee Kang, Yang Berbahagia Datuk Teknologis Dr. Haji Aminuddin Hasim, and Yang Mulia Academician Datuk Dr. Tengku Muhammad Azman Sharifuddin. Ladies and gentlemen, once again, thank you for being a part of this distinguished gathering and for honoring the memory of Dr. Ranjeet Bhagwan Singh. Let us continue to uphold his legacy by advancing research, supporting innovation, and fostering academic excellence. Assalamualaikum warahmatullahi wabarakatuh, and have a wonderful day ahead.